I'm a retired family practice physician, and I'm a little anxious about speaking before you today because in the past you've had a series of speakers who've been experts at the topics they spoke on. They spoke on things that they did in their daily lives, sometimes academic experts. And as a family practitioner, I was sort of a jack of all trades, but never an expert at any of them. And as I retired about 14 years ago, the things I'm going to talk to you today didn't really even exist as topics at that point. And so I got a lot out of the research that went into it, and I'm hoping that you will find some of what I say useful today. And the first topic I'd like to talk about is COVID. Now, COVID has been with us for a little more than 4 years, and thank you. Thank you. Forgot my duty here. Our relationship with it has really changed pretty dramatically over the 4 years. It's almost exactly 4 years since it was declared a pandemic. And it is sometimes hard to remember, but impossible to forget, images from the early period of big American cities essentially empty, without much traffic, without people on the streets. The traffic often was emergency vehicles transporting critically ill patients to the hospital. Hospitals totally overwhelmed with patients on every surface they could put them, beds, gurneys, ambulances sometimes waiting outside a hospital, unable to discharge the patient because the hospital had no place to put them. Hospitals without enough respirators to treat the people that needed them and having to make difficult decisions as to who got one, who didn't. Hospitals without enough oxygen for everybody that needs it, and families scrambling to get oxygen cylinders to bring into the hospital. And we certainly have come a long ways since those days. Now, the first slide shows hospital admissions tracked by the CDC since the beginning. For some reason that they don't explain, and I don't know, they start fairly late in 2020. I don't know why they did that, but you can see that hospitals' admissions rose and fell during that period. Similarly, if you look at the death rate by week, it rose and fell. And the good news from the first two slides really is that while there was a lot of COVID, a lot of hospitalizations, a lot of deaths for the first couple of years, in the last couple of years, it's become much quieter. Now, we're going to talk a little bit about what might account for these waves of COVID following by periods when there's fewer infections, fewer hospitalizations, fewer deaths. So one thing is the virus has changed. We don't have the same virus today that we started with, and we'll get into that in a little bit. When the virus first started, we were flying blind. We didn't have any idea what to do with it. It was spreading rapidly. It was clearly a serious problem. People were getting sick and dying, and something had to be done. And we made a lot of mistakes during that period. We've learned a lot. As people became infected and recovered initially, and then as we got vaccines, the population began to develop immunity. And so that factored into what the infection looked like. And the fourth thing is that there is some controversy about this, but there appears to be some definite winter seasonality to the virus. Now, this is a picture of the vaccination rate, and starting in late 2020, the FDA approved new vaccines for the COVID virus. This was a really historically quick response. And to come out with vaccines as effective as they were in such a short time was really remarkable. And as you can see, by this time in 2021, and that top line up here is people 65 and older. So by this time in March, a fair percentage of them had already been vaccinated, which is a remarkable thing. And then the other lines represent other age groups. Now, at this point, I'd like to talk a little bit about what a virus is and what happens in a viral infection. So this is a picture of a coronavirus. And you can see how it gets its name, crown, from its appearance. The little red pointy things on it are the spike proteins you've heard so much about. And then behind that is a protein capsule. And inside it is the virus's genome, which is a single strand of RNA. Now, when a virus infects a human cell, and this is a respiratory virus, so think about your nose, your mouth, your throat. Those are the places that commonly would be infected. So the virus attaches to a receptor that naturally is occurring on the surface of your nose cell. And when it's attached, then into the cell, the RNA is released. Now, a virus by itself is basically inert. If you had a test tube of viruses and left it for a year, at most you have a test tube of maybe a few left alive, but they can't do anything by themselves. Inside a host cell, the virus hijacks the machinery of the cell to then build more viruses. So a virus depends upon your cell to be able to go through its life cycle. So the first thing it does is it uses your ribosomes to make essential viral proteins. And then those viral proteins, some of which are enzymes, help the virus to replicate the RNA and build more of the capsule and the spike proteins, and finally to release those outside this host cell. Now, for a respiratory virus, when they're released, it could be into your respiratory tract. And then if you coughed or sneezed,
Put this over you.
okay, I'm going to trip, aren't I? That wouldn't be good. So if you coughed or sneezed, you would be exhaling viruses. Or it could be into your bloodstream, where it could circulate to other organs. Now, during a typical COVID infection lasting, this is a mild one we're talking about, lasting a week or 5 days, one infecting virus can lead to your body producing between 1 billion and 100 billion new viruses. Now, this happens by a process of doubling, and it takes about 33, 35 doublings to go from 1 to billions. And each cycle of this takes maybe 5 hours. Now, the virus has to replicate an RNA strand, which is a code of precise, it's got a 4-letter alphabet, and it's a code of precise sequence of those letters. And most of the time, when it replicates the RNA, it does so exactly. But occasionally, a mistake pops up, and that's called a mutation. And as you can imagine, when you're doing it over and over again to get from 1 to a billion or 100 billion, a mistake that occurs fairly infrequently is likely to occur. And when that happens, it is usually not good for the virus. I mean, random mistakes, and these are entirely random, are usually harmful. Occasionally, they're neutral, and even more occasionally, they're beneficial. And so they can affect the ability of the virus to replicate, that is to reproduce itself, to transmit, that is to spread to a new organ, a new person. They can affect how it interacts with our immune system, and if they make it likely that it'll evade our immune system, this is beneficial to the virus. And finally, they can affect the severity. So some strains are mutants that produce more severe infection, others don't. Now, evolution works through natural selection, and a virus that replicates more easily, transmits more easily, evades our immune system, has a selective advantage. Interestingly, a virus that produces a more severe infection may not have a selective advantage. And there were a couple of coronary, not COVID, but coronavirus infections that occurred in decades preceding COVID that produced significantly more severe infections. And what happened was people quickly got sick and had to be hospitalized. And so these didn't spread in the same way that COVID did. And so these infections flared up in other areas of the world. Middle East was where one got its name, and Far East. And then they disappeared. They did not become pandemic. And the reason they didn't was the infection was too severe. Now so one of the unique things about COVID was we were very good at being able to sequence the RNA genome. And so from early in the infection, we knew exactly what the genome looked like. And we could periodically check, and we knew when it had changed, when there was a new mutation. And so if you map this, starting here, you get branching and branching and branching and branching until we get way out here. And so the virus currently doesn't look anything like this original strain. Now, during a typical mild infection, lasting a week, producing up to 100 billion viruses, there really isn't much chance of getting more than a simple change to the virus. Now, we know from our experience that that occurs most of the time, but occasionally a new viral strain will come up that is very different from what the previous one was. And since we're monitoring this very closely, that difference is apparent. It's not that it happened gradually and we missed it and then suddenly we notice it. This is a sudden change. And it's thought that this occurs when the virus infects somebody whose immune system is sufficiently compromised that the virus can hang around for a much longer period and have a much longer period to go through repeated rounds of replication and develop multiple mutations. And so in the course of that infection, what you'll start with and what may come out at the end may be very different viruses. And this is happening periodically. Let's talk a little bit about vaccination. Well, first of all, so this shows a virus replicating in one person, and if several mutants arise, one of which replicates better than others, that will predominate within that person. If you have several mutations, the one that transmits better will be more likely to succeed. And the effect that'll have over time in a population. So the current vaccines we have are very good, but have a limitation. They produce what is known as humoral immunity, that is immunity that circulates in our blood. And it has been very good at preventing severe infections and deaths. It is not as good at preventing infections. And so you get people who get the vaccine and still get an infection. And that's frustrating. Our bodies actually have at least several levels of immunity. And the first level that the current vaccine does not induce is at the mucosal level. So we breathe things into our nose, and there's a level of mucosa that protect our nasal cells, and there are immune antibodies in that. And because the current vaccines don't induce that kind of immunity, people are still susceptible to being infected. We have known for a while that you can produce mucosal immunity, and for some other viruses, we have vaccines that do that. Some of them are administered as nose spray so that they directly act in that area and induce the immunity. And people are working on mucosal vaccines for COVID. They're probably a ways off still, but when they're developed, they should have the benefit of dramatically dropping the infection rate. And so, first of all, people will, I think, find this easier to understand. You'll get vaccinated and you won't get infected, rather than you get vaccinated, you still get infected, you just don't get a severe disease. And so I think at some point in the future, we can look for new kinds of vaccines. So currently, we're coexisting with COVID. It doesn't produce as severe an infection, and people are largely much more relaxed about the risk of getting infected than they were previously. So if you think of how things were 2 years ago or 3 years ago, we're much more casual in our relationship to the infection. However, it's still around. There are people in the audience today who have had COVID infections in the last couple of weeks. Mostly a month doesn't go by where I don't personally know somebody who has a COVID infection at that point. One of the ways that we track COVID is through surveillance. And in the early days of the thing, that meant PCR tests, which are the tests that you got in testing centers, in hospitals, and places like that. They had the disadvantage that often it took a couple of days to get the results back, but they were very sensitive. And so if you had a negative test, you could be pretty sure you didn't have COVID. And in the beginning, these were readily available. There were testing centers all over El Dorado County, and they were free, so that you never had to worry about the expense. And these days, they are no longer widely available. You really probably are most likely to get them in a medical setting now, and they're no longer free. So if your insurance doesn't cover it, there's cost involved. Now, a lot of people have switched in their daily lives to using home antigen testing. Home antigen testing is convenient. You can do it at home. You don't have to go anywhere. You get a result within 15 minutes, so you don't have to wait for a while to find out the results. It is, however, less sensitive, so that if you get a negative result early in an infection, it doesn't mean you don't have it. It just means that it may be too early for the results to tell. The other disadvantage is these aren't reported anywhere. So whereas with the PCR test, you could read regularly, and it would be in TV reports and everything, what the positivity rate was, how many people were being tested, how many of them were positive, things like that, that gave you a good feeling for the prevalence in the community of COVID. Nowadays, with home testing, you get no visibility, and PCR testing, really the rare people that end up being tested in medical settings. There is one other way that you can monitor it. It turns out that when you have COVID, you excrete it in your stool, and that if you test wastewater from a sewage system, you can detect the presence of the virus. Now, this obviously only works for communities that have sewer systems, so Georgetown, Pollock Pines, places like that, where it's septic tanks, this doesn't work. In El Dorado County, the two areas that are tested are South Lake Tahoe, and then there's a sewage system that kind of goes from Diamond Springs, El Dorado, Cameron Park, El Dorado Hills that is tested. So this shows the result for the Western Slopes testing for a year. The individual dots are individual test results, and you'll see that there's some clustering and then some outliers. Now, one of the things about testing wastewater as opposed to testing people is with people, you knew how many people were infected. With wastewater, you just know the level of the virus in the sewage. And for example, one person who may be excreting lots of virus and 10 people that may be excreting less will all look the same from the sewage level. And so you can see here, the solid line is an attempt to produce a moving average to smooth those out. So I think that this is a valuable resource now. It is reported by both the CDC and the California Public Health Department. And so if you're interested in finding this for the Western Slopes, and you do an internet search for wastewater COVID level, El Dorado County, California, and then look for the public health site, the California Department of Public Health site, you'll very quickly get to this, and you'll get to pick what county and what sewage system you want, and you'll see a graph like that. And so that's something I look at periodically when I want to know how safe or how dangerous it is to go out. So as I said before, one of the things that has happened is we have a much more casual approach to COVID. I mean, here we are all gathered together. There was a time not that long ago when we wouldn't have done that, or we'd all be wearing masks or something like that. And there are some experts that think we may be too casual. And one of the reasons is long COVID. So long COVID is just the presence of symptoms. And as you'll see, there's a wide variety of symptoms that are included in that occur at least 3 months after an acute infection. So if you have an acute infection and 3 months later you have symptoms, and it could be almost any symptoms, you may have long COVID. Now these are common symptoms of long COVID: fatigue, shortness of breath, chest pain, brain fog, and then a multitude of other systems. One of the difficulties of studying long COVID is because there's no simple, singular definition. Everybody who studies it has to come up with a way of identifying people with it. And they don't always look the same, and so the results aren't always exactly equal. So how often does long COVID occur? In various studies, somewhere between 10 and 30% of people who have a mild infection, this isn't an infection that gets you anywhere near a doctor or a hospital or anything like that, may get it. 50 to 70% of people who are hospitalized. If you simply survey a large group of Americans, 7% will say they have had long COVID at some point since the pandemic started. 3.5% will report having it currently. So this, at an individual level, is a low risk. At a level of the country as a whole, is a significant risk. Now, who is more likely to get long COVID? Well, if you have asthma, type 2 diabetes, are obese, and you saw how the severity of infection influenced it, or if you're a woman or older, those are all risk factors that increase your chance that you will get long COVID after an acute infection. So long COVID can, since it's defined simply by symptoms, it varies quite a lot in severity. So there are people that have brain fog, mild brain fog for a while after they have COVID and it goes away. Fatigue, mild fatigue goes away. There are also people who are severely debilitated by long COVID and really have difficulty on a daily basis doing ordinary things. And some estimates are that a quarter of the people who have long COVID fall into that category. So for people that have severe symptoms of long COVID, or that it lasts a long time, this is not a trivial illness, this is a big deal. Now, curiously, there are some strong similarities between long COVID, which has only been around since COVID, so in the last 4 years, and something that has been around much longer than that, that has bedeviled both patients and physicians, and that is chronic fatigue syndrome. We never really knew how to explain chronic fatigue syndrome, and so unfortunately it didn't help us with our understanding of long COVID. Now, long COVID was recognized fairly early in the pandemic. And as more and more people developed symptoms of long COVID, then medicine took this seriously and in a lot of cases set up long COVID centers to treat and study people that have it. And they put all kinds of specialties into these centers. So if you look at this, this shows different body systems and different symptoms. And then in the blue, it shows the sort of things that were discovered about people who had long COVID. And so on the one hand, you had a collection of symptoms, and then as you studied them and performed more and more tests, you found more and more abnormalities. And I'm not going to go through the details of this, but the message is that in the process, we know a lot about people that have long COVID. So this has been extensively studied. The people studying it have been experts. And if at the end of it, there are questions I can't answer or I'm vague on, that is unfortunately where it sort of ended up. So this looks at the percent of people in years from 2022 on reporting that they have long COVID, and it goes down. It doesn't go down dramatically, it's not disappearing, but it goes down. One of the perhaps most worrisome things about COVID is that if you look at a group of people who test positive for COVID and follow them for a year and compare them to matched controls who test negative for COVID, you follow for a year. If you test positive for COVID, this isn't being hospitalized, it's not being sick or anything like that, real sick, it's simply testing positive. In a year after you test positive, you are 3.5 times more likely to have a pulmonary embolus than somebody who tests negative. 2.5 times more likely to have a cardiac arrest. 1.7 times more likely to have heart failure. 1.4 times more likely to have diabetes. Now, if you're a young person, your base likelihood of having any of these things is pretty low. But if you're our age, these aren't negligible risks. And as I look at this, it certainly makes me think again about the risk of COVID. Now, how long does long COVID last? So at 3 months, 92% of the people who qualified continue to complain about it. And qualifying means you've had symptoms longer than 2 months, so it's not surprising that most of them last 3 months. But 69% at a year still have symptoms, and 41% at 2 years. So this isn't something that always simply goes away quickly. It has a tail. Now, with all the knowledge we have of long COVID, there isn't a simple explanation of why it occurs. And it may well be that there isn't a single simple long COVID. It may be a variety of different things that can happen after a COVID infection. So as I give you the options, these aren't either or options necessarily. It may be for some people this one, for some people A, B, and C, for some people D and E. It may be a mixture. So there is some evidence that in some people, more than 2 months after the infection, the virus persists. And it persists in areas of the body that are sort of hidden away and not as easily accessible. When we get an infection, our immune systems gear up a lot. And sometimes after the infection is gone, the immune system continues to be hyperactive and begins to cause damage to us, similar to autoimmune diseases. So autoimmunity is one of the things that may be involved. People with COVID are more likely to develop small blood clots, which can then cause trouble. And that is one of the thoughts of a contributing factor. There's evidence that it affects how our brains function. There is evidence that it can cause inflammation in our blood vessels. And this, again, can lead to a lot of things. And interestingly, one of the things that happens with long COVID is the population of bacteria that are normally in our gut and help to make us healthy changes. And interestingly, one of the more proven treatments for long COVID was to address the gut bacteria issue by infusing normal bacteria. Now, long COVID's been around for a number of years, and it has been addressed by a lot of really smart people, and a lot of things have been tried. There are some things that do seem to work. For example, if you have somebody who has long COVID and you vaccinate them, this is they've already got long COVID, you vaccinate them, it seems to have a definite improvement. Beyond that, there's lots of things that have been tried, but there are very few, if any, that have been proven to be effective. So if you were to get long COVID and go see someone, there's lots of things they would give to you, but they would give it with the understanding that we don't really know what the best treatment for it is. And a lot of the hospital systems that had put a lot of energy into setting up long COVID clinics in the hopes that they would have an effective treatment have sort of backed off of that, and to a large degree, it's back to ordinary physicians treating long COVID now. So, as I said, my conclusion from this is just I'm going to be a little more wary about getting it. The one sure way of preventing long COVID is don't get acute COVID. And that's all I have to say about COVID. Any questions at this point? Yes?
You just say don't get what?
Don't get acute COVID.
Acute.
Yeah, if you want to avoid long COVID, don't get COVID. That's unfortunately as good as it gets. Steve?
Can you talk about Paxlovid, how that works, potential rebound?
I didn't really include that.
Can you repeat the question, please?
Oh, yes. The question was to talk about Paxlovid. I didn't really include this in it because there was a limit to how much I could put in, Steve, so I would defer that. Yes?
If you have long COVID, you are no longer contagious anymore, correct?
The question is whether you remain contagious when you have long COVID. And to the best of our understanding, that's true. Certainly, with the viral persistence theory, you might be slightly infectious, but not nearly as infectious with an acute illness. Correct? Yeah?
Yes. I have a question. Many of us have kind of lost faith in the medical establishment. And let me explain one of the reasons. The medical establishment decided at the very beginning of the COVID thing to prohibit the prescription of ivermectin and oxychloroquine on the basis that they were not safe. Ivermectin had been in use since 1980, and there were over 3.5 billion, that's billion with a B, doses of it since that time, and it was found to be safe. It's on the list from the WHO, the World Health Organization, as one of the 10 most important medicines, but it was decided that it was too dangerous to use. And oxychloroquine was very widely prescribed for viral infections. And in fact, in the year before COVID, there were 4.5 million doses of it given just in the United States alone. But it was decided by the medical establishment that these were too dangerous to give. And they prohibited doctors from giving it. Doctors who prescribed it or advocated prescribing it lost their licenses.
You know, this wasn't an area that
There was nothing else at the beginning of infection. For example, a person that I know very well.
You know, this is outside of the area that I did any research on or have any expertise at talking to. So I would like to table that question. If you want to talk to me at the end, we can.
Yeah, but you're unwilling to share it with the answer with the group.
I don't have an answer. I didn't do any research on it.
You don't know why they were prohibited?
No, I don't.
Okay. Kind of uninformed.
Thank you. Any other questions? Yes.
Is there anybody that has a natural immunity? And if so, why?
That's an interesting question. I don't think anybody knows that. The question is, are there people that have a natural immunity? And there's certainly, you know, we're at a point now where most people have been infected. Some people haven't, or at least they haven't as long as they know. I don't think there's a good answer to that, but it's a great question, and I saw it pop up recently. Yeah. You.
I've seen a recommendation that seniors get vaccinated, another vaccination this spring. Any thoughts on that?
That is a recommendation. I think that people are playing around with that. I think it's, you know, it's the kind of thing that we won't, and the question was getting another vaccination in the spring. I personally think it's a good idea. I think that it'll be a while before there's hard data that supports that, but I would certainly go with that. Okay, I'm going to move on to my next topic. Okay, obesity. So, complete change. Obesity has been in the news, especially with the recent development of drugs that for the first time to be seen to be significantly more effective than previous drugs. And obesity is a complex problem because there's both a medical dimension, which we'll explore in a minute, to it, and a social dimension. So we have a society in which there's a good bit of shame to being obese. And I'm going to talk in part how it is clear now that obesity is not the result of gluttony and a lack of willpower, but is a result of hundreds of thousands, if not millions of years of evolutionary selection. But in any case, so obesity's been in the news. Obesity is defined by body mass index. And body mass index is weight in kilograms divided by height in meters squared. Now, most of us don't know what our weight in kilograms or our height in meters is, but if you go online, there are plenty of calculators where you put in your weight in pounds and your height in feet and inches, and it'll tell you what your body mass index is. And under 18.5 is underweight, 18.5 to 24.9 is normal, 25 to 29.9 overweight, and above that obese. Now the thing we're really interested in here is not BMI, it's body fat. And BMI is just an approximation. So for example, Governor Schwarzenegger in his bodybuilding days would clearly have had a weight to height that would made him obese. Now, as a bodybuilder, he made sure that he had as little fat on his body as possible so you could see all his wonderful muscles. And his body fat was very low. So in his case, it was not a good proxy for fat. Similarly, there are people who are naturally slender, don't have very much muscle mass, and have enough fat that they also have a risk from fat, but their BMIs would be perfectly normal. So the reason that we care about it medically is illustrated here. And along the bottom here, you have BMI, and these lines are mortality rates for men, these for women. And you see a low spot around a BMI of 23. And as you go on either side of it, the mortality rate increases fairly dramatically. So medically it's an issue because being obese carries with it the risk of morbidity, which means diseases, and mortality. And this illustrates mortality clearly. Now, among the diseases that are more frequent if you're obese, are cardiovascular disease. And remember that cardiovascular diseases are the leading killer of people in this country. Diabetes. If you carry more weight, your weight-bearing joints will wear out earlier, leading to osteoarthritis. And some cancers are more common with obesity. Now, interestingly, if you take a group of people who are in late adolescence and see where their BMI falls compared to their peers. So these are percentiles. So 50th percentile would be a BMI where half of their peers have a lower BMI, half have higher. And then you follow them through adulthood. So this is a longitudinal study looking over a long period of time. You find that those people who are fallen higher percentiles, higher percentile of BMI as an adolescent, so they were heavy adolescents, have significantly higher rates of coronary heart disease and cardiovascular death. Coronary heart disease is what leads to heart attacks. And both of those go up significantly. If you look at diabetes, this is women on the top, men on the bottom. This is diabetes. So the higher your BMI is, your risk of diabetes goes up quite steeply. High blood pressure, not as steeply. Gallbladder disease and heart disease at the bottom. Now, let's talk a little bit about what happened to people, how did obesity become a problem? And I think the answer has to do with evolutionary traits that over the hundreds of thousands of years that humans have existed and the millions of years that our pre-human ancestors existed, were actually very good traits for survival. So for most of that period, food was scarce, and abundance almost never happened. And so if you could, when food was available, store up as much as possible as fat, that was good, because it would get you through the lean times. And if your body was very good at not letting go of that fat during those lean times, that was better. And so we were evolutionarily hardwired to have bodies that became very good at putting fat on and very reluctant to let it go. And this was a tremendous advantage. Now, until fairly recently, that worked okay. And curiously, if you look at this chart, which shows the rate of obesity during a lot of my lifetime, it was stable. About 15% of the adult population was obese. And then starting in the mid-70s, it started climbing. And we'll talk about what may have caused that later. So the red lines are obesity in women, the blue lines in men. You have overweight, which is that thing between normal and obese, and then extreme obesity. So this looks at a little later period, and it's continuing to climb. And so as of not even that recently now, 42.4% of adults were obese. So obesity is a result of a balance between your intake of food and your output of exertion or energy. And it is unlikely that the change happened because our genes changed in any way. And it's unlikely that it happened because our basic mechanisms changed, because nothing happens that abruptly. I mean, those take hundreds of years, thousands of years, tens of thousands of years to change. So when you look at it, you really have to look at intake and output. And when people look at activity levels across that bridge where it was going along steadily and then started climbing, they are unable to detect any significant decrease in activity, either work-related or recreational, that would explain that rise. And similarly, they're unable to find any significant intake in the amount of fat in our diets to explain that. Now, the three things that seem to correlate are, during that time, there was documented increased consumption of sugar-sweetened beverages, increased consumption of ultra-processed food, and increased eating in fast food restaurants. So these things correlate with the rise in obesity. Correlation doesn't mean cause, but it's just suggestive. Now, one of the questions it doesn't really answer is, why are some people obese and some aren't? And part of the explanation may well be we don't all eat the same, we aren't all having the same activity. So if you believe that sugar-sweetened beverages, ultra-processed foods, and fast food dining are involved in the rise, then obviously people that don't do any of those things would be less likely to become obese. And people who eat out more and participate in that would be at higher risk. If you look at the genetics of obesity, there are some single mutations that almost inevitably cause people with those mutations to become obese from a very early age. This, however, is very rare. And so when you walk down the street, it is unlikely that any of the people you're seeing have these mutations. Now, when you take a group of people that are obese and a group that aren't, and do genetic studies on them, you find differences spread along about 100 different genes. And there isn't a single change that is predominant. So one of the changes may be 2.4% more than in the non-obese range. But there's no single place. It's just a lot of different genes involved in obesity. Now, during all this time that obesity was increasing, people were trying desperately to do something about it. And so people went on various weight loss programs. And I suspect that a lot of people were on more than one. Now, sometimes they would work, but the fact that obesity for a population continued to increase at a time when lots of people were trying these mean that in general these programs failed. And people were tagged if they failed with either being slaves to gluttony or having no willpower. And really the mechanism was that their bodies were hardwired by evolution to have exactly the traits that would make it very difficult to overcome obesity once you were obese. Whoops. So among the things that were tried, the one weight loss program that had the best success was bariatric surgery. This is where you modify a person's gut to make it so that they don't have as much room to eat and they don't absorb food as well. This is a very drastic solution and costly, and the very people who were most obese were also very high surgical risk, so it had some dangers to it. Drugs were tried with varying success. There were a lot of programs that could achieve about a 5%, maybe a little higher weight loss, but not much more than that. One of the drugs that succeeded at a higher weight loss was phentermine, but unfortunately, since from a medical standpoint we were trying to get people to lose weight to reduce their risk of cardiovascular disease, phentermine itself caused cardiovascular disease, so that wasn't a good solution. About 10 years ago, a new series of drugs for diabetes were introduced. Glucagon-like peptides, gastric inhibitory peptides. And they worked well for diabetes, and people noticed that obese individuals on these drugs lost more weight than they had trying anything else. And that as long as they were on these drugs, they kept it off. Now, hopefully these slides will come back because I have a really neat one. If you look at the effect of these drugs, they affect a whole range of things in our body. And they're almost a perfect solution to all the things that happen with obesity and that thwarted weight loss. So for example, people using these drugs, their intestinal systems would empty more slowly, and they would have more of a feeling of fullness. When you looked at their brains, they would have a decreased appetite, and they would have an increased satiety and increased energy output. And so as you looked through all the different body systems that made obesity such a problem to do anything about, a lot of them were addressed by these drugs. And so they were kind of a golden solution. Now the other interesting thing about the drugs was that when you looked at very high-risk people, high risk of developing cardiovascular disease, for example, strokes, and things like that, and you compared people with similar risks on and off these drugs, people on these drugs had about a 13% decrease in their risk of serious medical complications. So not only did people seem to lose the weight, but they seemed to lose at least some of the medical risk associated with the weight. So that was a good thing. Now, let's see if we get slides back.
Sorry, we're trying here.
Okay. The drugs are not without problems. So people on the drugs frequently had nausea and vomiting, and these drugs had to be injected by and large. They're not drugs that can be taken orally because they're complicated molecules that are easily broken down in our intestinal systems and therefore are useless once they get in. They also have some serious side effects: pancreatitis, gallbladder disease, and kidney impairment. And perhaps most worrisome, when you studied a group of people started on these drugs, at the end of a year, almost half of them had stopped. I'm going to go back briefly and sort of catch up a little. Not going backward. There we go, that's perfect. So this slide looks at several different drugs that were tried, and it compares placebo in the light with weight loss with the drug in the dark. And this is percent of body weight lost. And so orlistat was one that interfered with your ability to absorb fat. It had some unpleasant side effects, and it caused modest weight loss. Phentermine, which I mentioned earlier, caused more dramatic weight loss, but from a medical standpoint, since it increased your risk of heart disease, it was, if anything, a minus. And some other ones there were. So this is one of these new drugs. And you see that in this study, you get a weight loss that is substantially greater than with any others. Forward, yeah. So these are the names of some of the drugs that have been FDA approved for weight loss. There are other drugs that work equally well, but the manufacturers have not yet got them FDA approved. So this is just FDA approved ones. Whoops, there we go. There we go. So this is the slide that I really wanted. You can see that these drugs do all the right things to lots of different body systems. For example, they increase the breakdown of fat. They increase insulin, decrease glucagon. This is like the perfect setup for losing weight. So one of the difficulties of these drugs is side effects, discontinuation. It's worrisome to have a drug that works that well and that you have to keep taking it, because when you stop, you tend to gain weight back. And yet, only half the people are still on it at a year and only 30% at 2 years. I mean, that's not a promising pattern. Now, the other things about it that are kind of worrisome is these require injections. You have to inject yourself periodically. And the cost currently is about $1,000 a month. Now, at that cost, somebody has to pay for it. And if everybody who is obese currently took these drugs, the added cost would be about $1 trillion a year for the US, compared to the total cost currently of healthcare, $4.5 trillion. So it would be a huge increase treating a single disorder. Now, it might have some benefit in terms of reducing other costs, but it's hard to imagine it would reduce them by $1 trillion a year. So obesity treatment is an area where we have promising new findings. We have drugs that now seem to address the hardwiring for our system that made it so difficult to lose and keep weight off previously, but that aren't to the point where this is an answer for everybody's problems. For example, Medicare will cover these drugs for diabetes, but not for weight loss. There have been some healthcare systems that have started to cover them for weight loss, and then they looked at the cost after a while and they said, we can't afford this anymore. And these were public healthcare systems where the public was, taxpayer dollars were funding it. So I think that that's an issue. The conclusion I come away with for this is that the drugs are promising. I think they'll continue to improve, but I think we need to make a renewed, massive public health effort to try to reduce the number of children who become obese in the first place. Yes. Because once you become obese, it is very hard to fix. If you are lucky enough not to get obese, then it's a much easier problem. And so I think that really, unless we want to cough up a huge amount of money to treat it, we really need to start working with children who aren't obese and try to figure out how do you keep them from becoming obese. And that's all I have to say about obesity. Any questions on that? Yeah.
What about, with all the genomic work that's being done, is there, you mentioned there's 100 genes involved in obesity. Is there potential for genetic surgery and genetic manipulation down the road?
So the question is any kind of genetic-based treatment likely to help? And I think the problem, Patrick, is that so many different genes are involved, and each one contributes a little bit, but not a huge amount. So it's hard to know what you would target and whether treating any single gene would make a difference. It's a kind of a daunting task to think about what it would take to figure out which 25 genes you need to treat, and then finding effective ways of doing that simultaneously.
Would AI be able to figure that out?
Who knows? That's beyond me. Any other questions? Yes?
I have a question. 42% sounds like a lot, and I'm just curious, is that like an average number, or is that a focus group of like maybe our country?
So
or
the,
culture, or
it's certainly our country. And the advantage of using BMI is that weight and height are readily available. So numbers like that come from huge populations of people. Somebody has gone to a system which has 1 million heights and weights in it and calculated out BMIs and reports that. So it's not a small, study of 10 people or something like that. This is large populations. Any other questions? Yes?
Not with regard to obesity or COVID. I think in conversations, what most frequently talked about topics is the access to health care. Is there a light at the end of this tunnel? Are the schools ramping things up? What's happening on that?
Oh, access to healthcare. That's a great question. I don't have a good answer on that. It's something I'm concerned about, but I don't see anything. I mean, the problem with it currently is that's expensive. And we are reluctant to spend money on things. And it's probably public money we're talking about, so it's tax money. That's a more difficult question than I have an answer for. Yes?
What is the basic cost behind the expense of these drugs?
Oh, a big pharma question. John. What is the cost? What is the basic cost behind these drugs? So I don't necessarily have a great answer. I will say that other countries, so one of these drugs was developed by a Danish drug company. And in Denmark, the drug costs a quarter what it costs here. So a lot of it is just our reluctance to have the public purchasing power used to help reduce drug costs. These are complicated molecules. So for example, the two that are effective, the glucose-like peptides, glucose inhibitory peptides, are mimics of hormones that our body releases. Now our body is constantly releasing these, but it constantly removes them. So the first thing they had to do was they had to develop a form that was much longer lasting. Otherwise, you'd have to give yourself like 12 injections a day, which obviously never would fly. They're long strings of molecules, and this makes it harder to get them in the body. So it's good if they're released into your bloodstream inside you, but to get them in from the outside is a challenge. And then they're hugely profitable for pharma now. Pharma, the guys are building new yachts based upon these drugs. I think the cost will come down, but it needs to come down a whole lot if it's going to not bankrupt our system even more. Yeah?
what about the emotional effect on people and their weight gain? Do you feel that
that that has a tremendous effect on their inability to lose?
I think the shame of obesity has just made treatment that much harder. I hope that you got the message from what I said that once you're obese, our bodies have evolved over long, long, long periods to not get rid of that.
Yes.
They don't know the difference between being obese and losing weight and being underweight and losing weight.
So there isn't any way in the current studies that are, or the current solutions, that includes a way to change or to alter that or to cut off that need to grow back up? I know because I've watched my sister.
That is a great question. So the question is, currently we can get people to lose weight, but their bodies seem to want to regain it when you stop treatment. That's even true with the new drugs. My hope has always been that at some point after you've been at a new weight for long enough, your body will readjust. There's no evidence of that happening yet, but the new drugs are relatively recent. I think that if we could develop something that would reset your brain so that it wouldn't think that 250 was the right weight, it would go back to thinking 160 is the right weight, that would be tremendous advantage. It hasn't happened yet, though. Yeah?
Isn't there a difference between different obesity when you're 80 versus when you're 10? I mean, it seems to me that there's an age factor here, particularly in women maybe, that needs to be considered.
The question is, how should we include age in the way we think about obesity? And I don't have a solid answer for you. I'll tell you what I think. I think that if you're 80 and obese, and you can lose weight easily and it helps with things like the pain in your knees, the pain in your hip, the pain in your back, that's good. If you're 80 and obese and your diabetes is out of control and hard to control, losing weight may be good. But simply losing weight because it may add years to your life at 80 may not be worth the effort. That's an individual decision. I mean, I'm a year away from being 80, and so I'm facing that kind of thought, you know, how much effort do I want to put into adding an extra 6 months to my life if it takes a lot of work? I don't know. Any other questions? Yes?
Is there any similarity to RSV and COVID?
They're both viral infections. That's definitely a similarity. They both seem to have some seasonality. RSV affects a different population. So there are similarities, there are differences. So it's almost 1:30, and I would like to say a few words about artificial intelligence in medicine. I will keep it quite brief, and I'll give you just a few ideas of where it might help. But this is, first of all, I should disclaim that I've done a bit of reading in artificial intelligence. I couldn't possibly explain it to you. I can't even explain it to myself. I believe that specialized computers, these are not your home computer, these are special expensive systems with special chips in them, can learn, can be trained. I think the clearest proof of this is chess. So people have trained computers to play chess. In the beginning, they started out by trying to teach them the tricks of grandmasters. And then they found out that the way that really worked was you let a computer play chess over and over again. You reward it when it wins. You make it revise itself when it loses. Now, a computer can play chess very quickly. And so in a fairly short period, it can play 1 million games. And at the end of some point, the best computer systems now can beat the best humans. So AI has allowed computers to learn to play chess better than any human. That convinces me that machine learning is real. So I'm going to give you a couple of examples of where machine learning AI might help medicine. This is going to be much abbreviated, and I'd be glad to talk about it more at the end. So one of the challenges facing doctors currently is documentation. We've invented electronic medical records, and I didn't have to deal with them when I practiced, but my understanding is that a lot of physicians, after they're done seeing patients during the day, spend their evenings doing the electronic medical record. So people are working on AI systems that will participate in an encounter with a physician. And they'll listen in, and through voice recognition, they'll understand the words, and they'll be able to develop a transcript. Now, if you do that with some prompts involved, and prompts are the way you currently communicate with Siri or Amazon Alexa or something. For example, if you're examining a patient, you can't simply listen to their lungs. You have to verbalize what you find. That will allow the computer then to hear what you say, convert it into words, and to know what you said. And so during a visit, the patient tells you their story, they answer your questions, you examine them, verbalizing what you find. It can easily access things like blood pressure, EKGs, and stuff like that. And at the end of it, you say to the patient, I think you might have this and this. I would like to order this medicine for you at a particular pharmacy. The AI system will hear that, and it will contact the pharmacy with that prescription. You will say, I'm going to order the following blood tests, the following x-rays. The AI system will hear that, and it will generate those orders. I am going to refer you to a neurologist, to Dr. Smith, a neurologist. And it will set in works a referral. Now, at the end of this, the AI system is able then to create the electronic medical record. So as the doctor leaves that encounter, he'll be done. Won't have it hanging over him. That'll allow doctors a little more time to spend with patients. The AI system will, in the meantime, before the patient leaves the room, print out a summary at a patient's level of what occurred. So your doctor did this and this and this, and your doctor thinks you have this, and your doctor has ordered the following things. So you'll leave with all of that printed out. So you won't get home and somebody will ask you what happened, and you'll go, I don't know. Meanwhile, whoever would have had to order all that stuff in the doctor's office won't have to do it. Now, people are in the process of developing precisely such a system. So this isn't just imaginary. This is something people are working on. And so I think that in the not too distant future, we may have a system like that. It may make encounters more satisfactory to patients, more satisfactory to clinicians, more efficient and less expensive. Be a good thing. The other place is in the realm of medical diagnosis. So as a clinician, when you encounters a patient, you're trying to gather enough information to get some idea of what that patient has and what you should do for them. And sometimes, for example, in the emergency room, there are patients who are critically ill. You don't really have a lot of time to decide. You've got to come up with something fairly quickly and start treating them. And at the same time, you may have serious injuries, other serious medical illnesses you're distracted by. So first of all, you gather information currently. You have available, it's like if you're treated at Marshall Hospital and you go to the emergency room, they have available a vast amount of information on you. It may not be something that the doctor can readily get, but it's available. And then you combine all this information you've gotten, past and present on the patient, and you filter it against all the medicine that you know, and you come up with a diagnosis. So a computer can, in the same way that I just outlined, gather current information. It can immediately access all the digitalized information. It doesn't have to read through anything. It just goes zip, 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 and it's incorporated it. It can immediately access all of the medical information it's been trained on. For example, you could train a thing on every article published in any journal and every textbook. So it would know an enormous amount. And at the end of that, and without any significant delay, and without the distraction of having 4 different things it has to do at the same time, come out with a list of potential diagnoses. Now, medical errors are currently estimated to cause 800,000 deaths a year in this country. Medical diagnostic errors are a significant contributor to that. If, in the course of an ER visit, the ER physician could click a button on his computer and get the AI-generated list of possible diagnoses, in some cases he'd say, I already knew this, no problem. In some cases it might be things he hadn't thought about, but then he would think about, or she would think about. And in some cases it would contradict what they were thinking. But I think that it could help. Now, a lot of medical systems have a periodic conference where all the medical staff gathers and a complex patient that the hospital has treated is presented to an expert not involved in the treatment. And the expert gets to ask questions like, oh, what did their heart rate sound like? What did this test show on that? And at some point, the expert guesses what this patient has. Now, these are all patients that have gone through far enough so somebody knows with some certainty what they have. And at these clinical pathological conferences, remarkably, the experts often are able to guess. Now, a lot of ordinary physicians will go along and do the same guessing. And when they compared an AI system trained to do medical diagnosis on its ability to guess correctly compared to a group of ordinary primary care physicians, it did significantly better. Now, this is just a beginning result, but I think it shows a potential. Now, AI is the new gold rush for technology. It is the way, it's first of all fascinating intellectually. Secondly, if you haven't already made your first billion in tech, this is a spot you might do it. Medicine is very tempting to AI developers because medicine is currently 1/5 of our economy. So there's a lot of money there. If you can develop an AI system that healthcare will incorporate, there's a lot of money that could pay for it. I think that we need to be very careful that we do this very deliberately, that everything is thoroughly tested so that we understand exactly how it works in real life before it's incorporated. But I think that it's going to happen, and I think that it has a promise to improve our healthcare system. And for those of you who haven't figured it out, our healthcare system is in trouble. And I'm going to leave it at that today. I had a longer presentation, but I'm not going to bore you with that. But I will entertain questions on AI and medicine. Yes?
Do you think the companies that are most positioned to benefit the medical industry with AI are like software companies like Microsoft, Oracle, or whatever, or is it the medical companies that have internal people that know how to start using AI?
The question was what companies will benefit most from AI in medicine. I think it's going to be a mixture. I think that companies that are experts now at machine learning will dedicate units to medical issues. Now, those units will include a lot of people who know more about medicine than they know about AI, and try to develop systems that will benefit medicine and make them a lot of money. That's just a guess, though. I'm not currently involved in this, so I don't know for sure. Yes?
So when AI comes to play and physicians are dictating and the computer is doing analysis, who will need the malpractice coverage?
I would think that the medical systems would still need the malpractice coverage. I don't think this is like driverless cars. I think it'll be clear that if you're treated by this system, and they have incorporated AI, that if it produces a bad outcome, that system is still at risk.
Not the AI company that develops it?
Oh, I'm sure that'll be litigated, but I'm not a lawyer. I don't know how that'll play out. Yeah.
I'm just stuck in the 20th century, I guess, but how does the red line and the blue line get their information? I mean, is the patient talking to the AI recorder or whatever?
In these cases, these are published often, or at least they're transcribed in advance. So, for example, the New England Journal of Medicine publishes clinical pathological conferences held in Mass General. And so the information is all published. What they did was they fed an AI system a series of these things. So the AI system would get all the information but the final diagnosis. At the same time, a group of physicians would get all the information but the final diagnosis. And both of them would arrive at what they thought the diagnosis was. And the AI system outperformed the primary care physicians.
So like checks and balances?
I think initially probably there will, as this is incorporated initially, it'll work as a dual system. I think only as it proves itself as a way of doing this would we move to, I'm not sure we would ever move beyond humans being involved, but I think there would be a big benefit. So if I was diagnosing a patient, I would be delighted to have a computer suggest diagnoses to me. When I was in practice, I would often see patients that I said, I don't know what you have. I'm going to read tonight. I'm going to call you back tomorrow. I'll tell you what I think. This would be 1,000 times better than what I did, because I have to read textbooks and stuff like that. This will read everything in medicine, and it will immediately say, gee, this sounds sort of like this or this or this. We'll see. Any other questions? Yes?
I don't have a question, but I have a statement in that medicine evolves. I'm a retired nurse after 45 years, and I've seen treatments and diagnosis change over those years. So medicine is constantly evolving. So having something like AI that has the latest studies and findings available to everybody who has a computer would be wonderful. Because somebody in one state might do it one way, and somebody in another city might think it's something else. And that would really, I think it would be wonderful and beneficial.
So I agree. In practice, one of the real challenges was, and especially in family practice, which is so broad, was trying to keep up so that you weren't simply practicing the medicine you were originally trained on. Because medicine, in between the time I finished my residency and ended my training and the time I finished practicing, changed tremendously. And my understanding changed tremendously, and keeping up with that was a real challenge. Yes?
So I'm wondering what your thoughts are about the EMRs traveling with us as individuals. In other words, if I go to the East Coast, who's going to get, you know, am I going to have my medical records? When can I have those with me instead of at Marshall or along with Marshall?
That's a great question. So the ability of EMRs, electronic medical records, to travel. I think that needs to be worked out. I mean, there's obviously privacy issues involved and stuff, but I think it would be really great if you were visiting someone in a different state and went into a different emergency room, if the physician there had immediate access to information on you, especially if you're unconscious and you can't even tell them what medicines you're on.
Kaiser does that already. I can get all my tests and all my visits and everything that happens at Kaiser on my telephone.
Kaiser does that. Other systems do that. The VA is good at that. So if you see the VA in Virginia and the VA in Washington State, they all know. But I think there's a problem there. Patrick.
Ted, if you were to advise a young person interested in going into medicine, how would you advise them?
I've always thought that medicine worked well for people that enjoyed doing it. So among my peers in medical school, there were people there who at that point saw medicine as a way of making money. And there were people there who just genuinely enjoyed doing it. And I think the ones who were happier in the end were not the ones who went into it because they didn't want to become an investment banker or this or that, all of which paid about the same, but the ones who actually enjoyed the interactions, the challenges, stuff like that. I think that AI has the potential to make, I mean, currently with the COVID pandemic, I think a lot of clinicians are discouraged. They're now working for someone else, not themselves. They have to see so many patients a day. They have to do electronic medical records. It's just a lot, and that's discouraging. I think AI has the ability to streamline that and to improve both the clinician's experience of practicing medicine and the patient's. And both of those need improvement. Neither of them is satisfactory currently. Any other questions?
How soon would you think AI would be in the average large hospital?
I'm going to guess it'll be, I think it'll be sooner than it should be. I mean, I really think that it has to be done very deliberately because medicine is not something you want to put in a system that has critical relationship to outcomes and then discover a while later that your plane can't stay up in the air or your door falls off or whatever. So I think it has to be done carefully, but it's such a lucrative field that I would guess within the next year in some form or another, and I can't guess what that'll be, it'll be there. Yeah?
Ted, who do you think will regulate AI? FDA? Who's going to approve it?
Who will regulate AI? I don't know, Steve. I don't know. I mean, you know, there are people that think we're over-regulated now, should just do the Wild West and let people do what they'll do, and, you know, and I don't know how that'll work out. That's a battle that's being fought on many fronts. Any other questions? Well, thank you.